Then as now, one of the most important factors for women and children seeking support is the fear of service providers not believing them. So there's just a few studies looking at the impacts of adult sexual assault. 1978 saw the formation of the New South Wales Task Force into care of victims of sexual offences. Under the Rand government, new law reforms were enacted which for the first time recognised that men could be raped and that rape was a crime of violence. And that was a very critical change under the law. Metropolitan services called help centres were established by the Department of Health, followed by a rollout across the state in following years. Services were first established in hospital emergency departments because it was believed that victims of rape must be badly injured. It became clear soon after their establishment that physical injury was not a primary issue, as coercion and threat were more commonly used as a tactic of perpetrators, and services were later set up in community health settings. Most importantly, these services were set up with feminist-based understandings. Now, for children, the process has been more complicated. Historically, much as women, children have been viewed as the property of the father, though, as we know in more recent years, particularly with the family court, it's more as property of the parents. Though child abuse and child sexual assault was known to exist, there was a wall of silence around it until adult survivors of child sexual assault spoke out about it in the early 1980s. In fact, sexual assault services were initially set up to respond to adult rape. It wasn't until the Australian Women's Weekly invited women to respond to an open survey on broad social issues, which included a series of questions about incest, that the extent of the problem was uncovered. Over 30,000 women wrote in about their experiences of being sexually abused as children, and this survey was then followed up by a number of phone-ins nationwide which confirmed the extent of the problem. Just to give some indication of how silent these issues were, in 1980 there were 16 notifications in New South Wales for child sexual assault. By 1986 this had grown to 3,000. I'd also say that when I was working in the late 70s, if a child was sexually assaulted and it came to the attention of service providers, that child was charged with being in moral danger and removed from the home. The offender remained in the home because it was felt that the breadwinner was important to provide financial support to the family. There wasn't a consideration that this might happen to other children. It was more seen that the child was being seductive or somehow attracting that abuse. In 1984, child advocates and the women's movement were successful in having the Rand government institute the New South Wales Child Sexual Assault Task Force. Recommendations from this report were supported by Cabinet and resulted in the provision of child sexual assault programs across the state, as well as the introduction of mandatory reporting. An integrated model for response was signed off by the Premier, and this is the model that we still work under today, though of course it's had many modifications. And I would add here that it's not a human's right, it is based on human rights, but it doesn't hold the rights of the child. A child can't just ring up and get a response to a sexual assault. We have to go through a very complex and difficult system. And that's also food for thought, I think, for this conference. So the Education Centre Against Violence was established as the Sexual Assault Education Unit in 1985 with 2 trainers to provide training and resource development in the areas of child and adult sexual assault. And that was to provide this across the state. This followed the findings of the reports of the New South Wales Sexual Assault Committee and later the New South Wales Child Sexual Assault Task Force, both of which were convened by the Women's Coordination Unit, the Premier's Department under the Rand government. In 1990, the Centre's brief was extended to include domestic violence education. In 1997, we were funded to expand provision of professional training in the area of physical and emotional abuse and neglect of children, and we changed our name to the Education Centre Against Violence. In 1998, we were funded to develop and deliver the Certificate 4 in Aboriginal family health, family violence, sexual assault and child protection, and that's been expanded to include the Advanced Diploma in Aboriginal Specialist Trauma Counselling. And I'd like to acknowledge Judy and Carolyn Atkinson from Southern Cross University for their support to ECAV around those programs. ECAV's been delivering programs by Aboriginal educators into Aboriginal communities and to workers since 1989. So despite the high number of survivors of child and adult sexual assault, child abuse and domestic violence consumers using mental health services, mental health practitioners and policymakers here in Australia, America and the United Kingdom remained resistant to changes brought about by the women's movements of the 70s and 80s. Disclosures of sexual abuse in particular were often framed as evidence of mental illness or disorder. Despite the release of psychiatrist and feminist author Judith Herman's groundbreaking book Trauma and Recovery in 1992, little changed in New South Wales regarding mental health service provision. In 1992, after consultation with the mental health sector, the Education Centre began to deliver a 3-day workshop on adult and child sexual assault to mental health workers. I joined the organisation in 1994 and I was somewhat shocked, really, to find that I would be training entire workshops of mental health workers, many who'd been in the system for decades, who would tell me they had never worked with anyone who'd been sexually assaulted, not ever. We've come a long way since then. Staff attending that training mainly did so in their own time and at their own expense, as mental health managers did not see the relevance of sexual assault training to mental health practice. They could understand suicide training and suicide prevention, but it literally wasn't in their language, it wasn't in their field of sight. So for some time I attempted to engage policymakers around issues of sexual assault, but I was remarkably unsuccessful. To engage with a network of like-minded women, I joined the community organisation Women and Mental Health, which was established in 1993. The women on this committee were consumer activists, concerned family members, and committed service providers. Everyone came together in the recognition that women's needs were not being met through mental health service provision at that time. So the committee applied for and were awarded a grant in 1995 to attempt to break the silence around the topic of the sexual abuse of women patients during admissions to psychiatric hospitals and units. Now, the Burdekin report had raised some of these issues for discussion, but Women and Mental Health used to hold a very small conference annually which encouraged consumers to get up and talk and to present. And regularly, women would get up and talk about being sexually abused in acute admission facilities or in step-down or rehab centres. So that committee applied for and received funding, and the Safety for Women in Mental Health Services project resulted in the research report Every Boundary Broken. Jane Davidson conducted that research on behalf of Women and Mental Health, and it was launched in December 1997. So this is just looking at the definition that was used by the participants in the research. And you can see that it includes a continuum of sexual assault from touching, masturbation, exposure, through to penetration. And some of the sexual abuse was couched in terms of a relationship. In every case, that was abuse by staff members. Some of the women had been abused on one occasion, some had been abused more than once by different perpetrators, some had been re-abused by the same perpetrator on different admissions, and some the abuse had continued for many years. Again, the latter type were all perpetrated by staff members, and these women had not disclosed to anyone prior to the report. Another interesting finding out of that research was that acute admission was the most unsafe place. It was for women. A central finding of the inquiry into responses to disclosure or witnessed events from this report was the fact that belief was linked to action. If staff, other than those in the research, didn't believe the victim's disclosure, then no positive action to respond to the sexual abuse was taken. It really came down to personal judgments. Usually the disclosure was perceived by staff to be acting out or manipulative behaviour or an exacerbation of the mental illness. Negative consequences such as an increase in medication, ECT or delayed discharge was the common response. And another interesting finding was that the staff who believed and supported the women often found themselves isolated or targeted by other team members. So both the consumers and staff talked about the mental health system as a boys' club or culture. So from this research and a draft model of best practice in identifying and responding to sexual assault, which was developed and distributed at the time of the launch, funding from the Centre for Mental Health was made available to ECAV for training into the mental health sector on adult and child sexual assault. The training was supported by the release in 1999 of the Guidelines for the Promotion of Sexual Safety in New South Wales Mental Health Services. The funding enabled an expansion of the training, and with direction from the Centre for Mental Health, staff were released to participate. I'll just say now that the mental health and sexual assault team, who deliver a lot of training, including into acute admissions, rarely now have anyone attending workshops who say they've never worked with anybody who's been sexually abused. In fact, they come along to find out ways to work more effectively in the complex structures that of their workplace. The guidelines provided a wedge into the system that enabled and encouraged discussions to take place about sexual abuse, both within mental health services and more broadly. The guidelines included information on child sexual assault as well as adult survivors, and over time, and as interested clinicians began to engage with the issues, some services started to offer groups for adult survivors and to develop local policies and procedures to better meet the needs of this client group. One of the recommendations of the guidelines was that area health services establish sexual safety committees, which would include representation from consumer workers as well as sexual assault services. Now, I participated on a number of these committees and often found myself in the role of interpreter. It was very interesting to note that mental health and sexual assault services at the time, even though they used the same words, did not have a shared language. And there were extraordinary struggles on those committees to try and get something sensible out at the end. For violence response services, a critical intervention in abuse dynamics is to support the victim and to place the responsibility for the abuse and the devastating impacts of the abuse onto the perpetrator. That is a key dynamic in work coming out of violence prevention services. But in mental health services, the word responsibility is spoken about in terms of consumers' responsibility for their own mental health. Also, a critical focus of the violence response services is to stand beside the client and believe stories of trauma, rather than to take an expert position that questions the validity of the client's narrative, particularly as it relates to their mental health. Now, though this is a bit of an oversimplification of the issues, I think it does provide a small window into understanding why collaboration between services can be so fraught.